So to begin with, we know that head neck cancer is one of the most common malignancy in our country. So the common reasons being the smokeless tobacco that is very common in our country, the use of gutka, ericanite, etc. So a few years back, there was hardly any treatment possible for stage 4 or recurrent head neck cancer. But over a period of time, there have been lot of new drugs and new research have come up. So now we can offer plenty of treatment options to our patient. So to begin with, in the 1970s, there was only a single agent drug that was active in head neck recurrent head neck cancer, and which gave an overall survival of 6 months. So it was till 2010, it was considered only a surgeon's disease with some role of radiation. So after 2008, then the role of chemotherapy and targeted therapy came into the management of head neck cancers. So in 2008, the extreme trial came by Dr. Vermorken, which demonstrated an improvement in outcomes with cetuximab, which was added to chemo. In 2016 and 2018, immune checkpoint inhibitors therapy came and they demonstrated improved survival in patients who were platinum refractory disease, or they were also approved in second line. In 2019, we had multiple treatment options after Keynote 48 and a TP Extreme trial. So we had option of combination of IO plus chemo, and we have option of combination of chemo, taxane, platinum, and cetuximab. So in 2020, the issue is how do we sequence it? How do we sequence the treatment option that is available to provide the maximum survival benefit to our patients? So the survival with the best possible sequencing has been improved from 6 months to 21 months over the last, I can say last 10 years. So in this presentation, we'll be discussing what all treatment options we have and what should be the possible sequence option as of now in the patient of recurrent or metastatic squamous cell head neck cancer. So we know that head neck cancer patients, they have multiple issues. They have difficulty in speaking, they have difficulty in eating, they have difficulty in breathing. They frequently have pain. They also present with tumor bleed. They have nutritional problem. So the aim of the treatment is primarily to induce a response, which ultimately should translate into a survival benefit. So symptom burden is greater when we have a bulky tumors as compared to a smaller tumor size. So that is very obvious. So in this controlled prospective study in 127 patients with squamous cell carcinoma of head neck who were treatment naive, it was found that those patients who had a higher treatment burden had a higher incidence of pain, appetite loss, and fatigue. So basically, for head neck cancer patients, so it's important that we achieve a good response so that we palliate the symptom of the patient, and we want this response to later on translate into a better survival benefit. So quality of life really matters in managing head neck cancer patients. So 80% of Indian recurrent metastatic squamous cell cancer patients are symptomatic. So why Indian? Because majority of the head neck cancer patients are Indian. So proportion of patients, around 78% are symptomatic and 22% they don't have any symptom. So what should be the primary objective of treatment? Obviously, the primary endpoint is overall survival, but the response rate is also very important to improve the quality of life and to provide symptomatic benefit to our patient. So coming to the treatment options that we have for treatment of recurrent metastatic head neck cancer. So this was a 2008 publication, a landmark paper which was published in NEGM by Dr. Vermorken. So this was a phase 3 trial of combination of chemotherapy with cetuximab in first line setting. So in this, around 442 patients were randomized to either chemotherapy or chemotherapy plus cetuximab, and cetuximab was continued till progression. Chemotherapy that was used in this trial was cisplatin or carboplatin, and that was combined with 5-FU, which was given for 4 days, and each cycle was repeated every 3 weeks and was given for up to 6 cycles. Cetuximab was given at a loading dose of 400 milligram per meter square, followed by 250 milligram per meter square weekly. The primary endpoint was overall survival. The secondary endpoint was PFS, overall response rate, disease control rate, duration of response. So in this the study, the 5-year follow-up result showed that the arm of cetuximab in combination with chemotherapy showed a significant survival benefit even at the end of 5 years. That was 10.1 months as compared to 7.4 months in the chemo arm. That was also statistically significant. And this is the long-term data that we have of this trial. So from very beginning we were not comfortable using 5-FU as a 4-day infusion in combination with cisplatin in clinical practice. So we already, most of the clinicians used taxanes and platinum in clinical setting instead of 5-FU and platinum in combination with cetuximab. So this is what this slide is trying to show, that there are multiple chemo partners can be given with cetuximab, and that should include cetuximab and a platinum. So what are the treatment partners that are used? So you can see how this slide beautifully expands. So we have combination of cetuximab with platinum, which can be either cis or carbo, and that can be combined with either taxanes, which can be either paclitaxel or docetaxel, or it can be 5-FU. So 5-FU generally is not feasible because of its difficulty in administration and toxicity profile. So it's generally we use taxanes in clinical practice. So we have now evidence that we can use taxane and platinum, and that can provide a better survival as compared to 5-FU and platinum. So this was proved by TP Extreme study, which was also the PI was Dr. Vermoken. So it was a combination of cetuximab with platinum and taxanes. So in this setting, around 541 patients of first-line recurrent metastatic head neck cancer, they were randomized to either cetuximab, 5-FU, and platinum for 6 cycles, or the other arm was cetuximab in combination with platinum and taxanes. The taxane was docetaxel or paclitaxel, and cetuximab was continued till progression. So in the TP Extreme trial, the side effect profile was favorable as compared to the Extreme trial. So grade 4 or worse adverse event was present in 36% in TP Extreme as compared to 52%. And the ease of administration obviously is better in TP Extreme trial as compared to Extreme trial. And the survival results are now best possible results till date. That was around 14.5 months as compared to 13.4 months. And the response rate was similar, around 57 and 59%. The number of cycles that were given in TP Extreme were 4 cycles as compared to 6 in Extreme trial. And the major contraindications in Extreme trial are cardiotoxicity and GI toxicity. And the maintenance therapy was cetuximab in both the arms. So this is a slide which summarizes all the trials which have used cetuximab as one of the treatment arm in combination with the chemo. So you can see that all these trials have consistently shown a better response as compared to chemo alone in combination with cetuximab. In TP Extreme, it was 14.5 months, and in the Extreme arm of TP Extreme, it was 13.4 months. So all the landmark trial, they have shown that combination of cetuximab and chemotherapy have results in a significantly better survival, that is around 13 to 14.5 months. So after the TP Extreme trial, so now it's very convenient, and we have a backup of a well planned randomized trial that we can replace 5-FU with a taxane in the Extreme regimen, and it seeks to take advantage of the potential immunogenic and pro-apoptotic synergy between cetuximab and taxanes. And this combination is also highly convenient to administer, and these combination treatments may be of importance to patients with high tumor burden, where we want a better response because of the symptomatic disease burden, and also because of the dangerous site involvement, which can cause risk of stridor, risk of bleeding, risk of ulceration or dysphagia. And in these patients, symptomatic relief is a key treatment goal. So currently, and is also a clinically beneficial option for patients with contraindications to 5-FU. So we have one more first line option which was approved on the basis of Keynote 48 trial. So this is not yet DCGI approved, but this is also a very good option. So in this recurrent head neck cancer patients, they were randomized to combination of chemo. Chemo was platinum and 5-FU, and it was combined with pembrolizumab. So it was found in this study that this also results in a clinically meaningful improved survival, but the survival was limited to patients who had a PDL1 CPS score more than 20. So in those patients who had a CPS score more than 20, then this combination of immuno plus chemotherapy resulted in median OS of 14.7 months, which is similar to the TP extreme data, and as compared to 11.1 months with a hazard ratio of 0.62 and a clinically significant survival benefit. So when we include the patients who are PDL1 CPS score more than 1, then there was 13.6 months median OS with immuno and chemo combination as compared to 10.6 months in the chemo arm. So I'm sorry. So out of the 29 patients in the CPS score more than 1, 22 patients were from the CPS score more than 20 subgroups at 4-year follow-up. So long-term outcomes from Keynote 48 in the pembro monotherapy, it also showed that the higher survival is mostly limited to the patients who had a CPS score of more than 20. So the median overall survival was 14.9 months in the CPS score more than 20 as compared to 10.8 months. And in the patients who had a PDL1 CPS score of more than 1, the benefit was 12.3 versus 10.4 months. The overall survival in the CPS score is possibly high because it also included patients who had a CPS score of more than 20. So in the Keynote 48, the patients who had a CPS score of 1 to 20 group, they has a lesser median overall survival than in the intention to treat population, as well as in the CPS score more than 1. And in patients who received pembro monotherapy, then the CPS score 1 to 20 group had a lesser median OS. And in patients who received combination of chemo and IO, in patients with CPS score 1 to 20, it had a median score of 12.7 months. So that is still lesser than the extreme and TP extreme data. So after the Keynote 48 trial, we can say that we have an option of combination of immuno and IO, but there is no head-to-head comparison between the TP extreme and IO and chemo arm. And in this study, the benefit was probably limited to those patients who had a CPS score PDL1 of more than 20. So although it is an option, but it should be applied only after consideration of clinical situation, and it is still not DCGI approved because I had problems giving this combination to ECHS patient. So they didn't approve for one patient. So extreme may be the preferred treatment option in Asian patients who had a CPS score of less than 20, and it results in a median longer OS and an improved response as compared to pembrolizumab and and platinum and 5-FU combination. So these are subsets of patients who had a CPS score of less than 20. The overall response in extreme as compared to pembro plus platinum and 5-FU in Asian patient was 14.3 in the pembro arm and in the single agent pembro, and in the extreme it was 41.5. And in the combination of IO plus chemo, it was 31.6%, and in the extreme arm, it is 40.8%. The OS with extreme versus pembrolizumab plus chemotherapy in Asian patients in the intention to treat population, it was around 10.4 months versus 10.8 months. So there is possibly a numerically longer OS and a better overall response when we choose combination of cetuximab and chemotherapy as compared when we use pembro plus platinum plus 5-FU. So probably when we need a better and faster response, then the cetuximab and chemo combination should be the preferred first-line treatment option. So the problem with the Keynote 48 study that majority of the patients they included in the study, they were oropharyngeal carcinoma. Whereas in clinical practice and when we consider the actual incidence, it's around the 60% of the patients are oral cavity cancer. So it is not right that we extrapolate the data of oropharynx to oral cavity cancer. and apply that to clinical practice. So the higher number of oropharyngeal patients in Keynote 48 trial may be responsible for the better overall survival. However, in clinical practice and in real world oral cavity tumors, they are highest among the Indian and the Asian populations. And in the real world also, the combination of cetuximab plus chemotherapy has demonstrated a consistent overall response rate and overall survival in Asian populations in clinical trials. So the overall populations with cetuximab plus chemotherapy in Asian populations is around, can be up to 77%. So this paper was published by Max group of hospitals. Dr. Ankur Behel was the PI. So you can see that the response rate ranges from 36% to 77%. And in the overall survival with cetuximab plus chemotherapy in Asian population ranges from 11.8 months to 14.1 months. So this is the same study that was published by Max group of hospitals by Dr. Ankur Behel. So in this study, they found that patients who around 140 patients were given chemotherapy with cetuximab, and 89% patients received only chemotherapy. The response rate was 77% in the cetuximab arm as compared to 45% in the chemo plus cetuximab arm. And you can see the drastic change in the progressive disease. So around 47% patients progressed in the chemo arm as compared to 15% in the cetuximab arm. Also, the survival was significantly more in the cetuximab arm, around 11.8 months versus 8 months in the cetuximab arm. In the Keynote 48 trial, the overall response was low as compared to the cetuximab, and progressive disease was also higher with pembrolizumab monotherapy. So we know that there is a phenomena called hyperprogression when we use a single agent IO, and that phenomena is more common in head and neck cancers and in the non-small cell lung cancer. So this can be a problem when we use only single agent IO in treating head and neck cancer patients. So you can see that the incidence of progressive disease. So in those patients who had a CPS score of less than 1, then the progressive disease incidence was around 50% as compared to only 8.9% in the extreme study. In those patients who had a CPS score of 1 to 20, the incidence of progressive disease was 46.8. And as in the extreme study, in CPS 1 to 20, it was 15.8%. And in those patients, even in those patients who had a CPS score of more than 20, the incidence of progressive disease was 31.6% as compared to 9.8% in the extreme trial. So this is a cause of concern when we use only IO as a single agent therapy in the first line setting. Then there can be a risk of hyperprogression, which may be difficult to manage in subsequent settings. And this slide is showing that what should be our strategy in this above mentioned scenario. That is, does the low response rate and high progressive disease, that means that if the patient progresses after pembro plus chemotherapy, then what should be done? What is the possible treatment option? So that, as I discussed, that hyperprogression is defined as the acceleration of tumor growth following treatment with IO. So in early progressive disease is defined as those who progress in less than 3 months, and late progressive disease is defined as those who progress in more than 3 months. So early progressive disease, around 24% patients have that phenomenon of hyperprogression, and late progressive disease is present in up to 50% of the patients. So with the same slide that I showed, that almost double the rate, there is almost double the rate of progressive disease when we use IO plus chemotherapy in a first line setting. So we should be very confident that the treatment option that we are using should benefit the patient, because if we use a wrong treatment option, then we will be in a fix what to use in the second line setting. Because if we use the combination of platinum 5-FU or taxane carbo, then we have to identify a chemo partner with cetuximab also in second line setting. Whereas we know that in second line setting, we have enough data of nivolumab and pembrolizumab, which can be given as a single agent, and which has shown a very good response rate in second line setting. So we don't want to waste our treatment option. We don't want to waste the option of cetuximab in the second line. So I think that in those patients who we need a rapid response, where the CPS score is less than 20, then definitely the treatment option should be cetuximab and combination of chemo in the first line. And we should reserve IO as a single agent in second line. So you can see from this table that the incidence of progressive disease is around 8% in the TP extreme study, and in patients who had a CPS score of more than 20 and they were treated with IO and chemotherapy, the incidence of progressive disease is still higher in 15%. So what could be the right sequence for recurrent metastatic squamous cell head and neck cancer? So either it can be cetuximab and chemotherapy in first line followed by IO in the second line, or it can be combination of IO with chemotherapy followed by cetuximab and chemotherapy in the second line. So what is the present data that we have to suggest that what should be the better treatment option? So this was presented in ASCO 2020. The second line treatment, the overall survival since randomization in each arm according to chemo plus minus cetuximab versus IO. So you can see that in the left side is the extreme arm where second line treatment with chemo and cetuximab was given, and in the second line with IO was given. You can see that when we give a second line treatment with IO, then the median OS is more. It is 19.4 months as compared to 17.6 months. So similarly in the TP extreme trial, when we give a second line IO as compared to cetuximab and chemo in the second line, then the survival is significantly more, 21.9 months as compared to 14.9 months. So I think there is no doubt that if we have not used IO in the first line, then IO in second line, it has proven to be significantly better as compared to chemotherapy. So overall survival in the second line treatment, the overall survival since randomization in each arm according to chemo plus minus cetuximab versus IO. So this is the graph of the figures that I discussed. It is 19.4 months when in the extreme arm as compared to the extreme arm in the favoring IO, and in the TP extreme arm in the second line it is 21.9 months. And there is also a data from our center from Dharamshila with collaboration with Kolkata. So we selected our patients who received Paclitaxel and cetuximab or 5-FU platinum cetuximab in the first line, and in the second line those who received nivolumab in platinum sensitive patients. So we found that the overall response rate is comparable what we have in the real world, that is around 79% in patients who received chemo plus IO, and a median PFS was 7 months. And patients on second line treatment, that is around 33 patients, they received 19 patients received nivolumab and rest were put on metronomic chemo. So in the nivolumab arm in the second line setting, you can see that the median OS is 20.4 months and with a response rate of 37%. And whereas in metronomic chemotherapy, when we give after cetuximab, we need to understand that after platinum therapy in platinum refractory or in patients who have progressed on platinum, this response rate is only limited to 10% with a median PFS of 2 months. So in this real world data, we can show that in the second line setting, nivolumab can show a significantly better survival as compared to the other options, that is chemo or metronomic chemo. So this is another study. This is a retrospective Japanese study of 100 patients, which revealed that patients receiving second line treatment following the extreme trial regimen in first line had longer survival than those without. The median PFS was 13 months versus 3 months. So in this also the second line was nivolumab. So we have enough data that in second line setting we can use either nivolumab or pembrolizumab IO, and it has shown a better outcome as compared to the chemotherapy arm. But in the first line setting, we still need to decide what should be the standard treatment, either IO plus chemo or cetuximab plus chemo combination. So as of now, I think the standard of care should be in those patients we need a rapid response, and in those patients who have a CPS score of less than 20, then the cetuximab and chemotherapy no doubt should be the first line treatment option. So the problem with giving IO and the chemo in first line is the problem of hyperprogression. So that can be a troublesome problem when we use IO and chemo in the first line setting. So I think as of now, till we have more robust data, so we should leave IO in the second line setting, because it will be difficult for us to find a chemo partner for cetuximab once we have exhausted the standard platinum, taxanes and 5-FU in the first line. So I think this is my last slide. So cetuximab is an important part of the treatment sequence in patients with recurrent metastatic squamous cell carcinoma of head neck. And apart from response rate, quality of life, apart from overall the survival response rate, quality of life is also an important endpoint for management of head and neck cancer patient. A rapid response is required for patients with high tumor burden patients and those with aggressive tumor growth. Cetuximab plus chemotherapy have provided a rapid response and consistent efficacy in multiple trials, regardless of the PD-L1 status. And cetuximab-based treatment regimen can be combined with multiple chemo partners in recurrent metastatic squamous cell carcinoma of head and neck patients. And do we have enough evidence on IO inhibitors? I think that as of now, in first line setting, still we don't have enough evidence. Yes, but maybe in future there may be. As of now, data of combination of chemo and cetuximab, it is more robust. Problem with IO that I discussed was a lesser response rate, increased incidence of hyperprogression, lower PFS, and difficulty in finding a chemo partner with cetuximab if you have used the combination of IO and chemotherapy. So with this, I would like to conclude my presentation. And if any questions from anyone, they are welcome to ask.